Hello, everyone. My name is Esteban. I'm one of the PGY1s for those of y'all that haven't met me. And my clinical pros today is going to be on alcohol withdrawals and treatment strategies. So just to jump off the bat, table of contents wise, we're going to go over some cases, afterwards manifestations, and then general treatment strategies for this. And I thought this is an important topic given that, especially on overnight shifts, we see a significant amount of patients with alcohol use disorder. And a lot of those patients tend to have withdrawal. So it's worth having at least a little bit of familiarity with all this. So say you're on pod back overnight, 2 a.m., you look at the board, you see chief complaint, alcohol intoxication. So first thing off the bat, Dr. Silverberg and Dr. Gennaro recently talked about this. You want to check your biases at the door. It's not, you can't go with these patients and think it's just alcohol intoxication. So you want to make sure you're always doing a good head to toe exam, especially a neuro exam, and you want to reassess often. So you see the patient, 54-year-old male, no past medical history because new to the system, here for alcohol intoxication, last drink 6 hours ago, has been drinking all day, doesn't really remember much until waking up here, is getting a little irritable with all your questions, states he really just wants to sleep, and review systems notable for mild headache and stomach pain. And so you've already gathered time since last drink, but question for the crowd, what additional history would you want to elicit regarding their alcohol use? Good, yeah. So history of DT is a big one. Daily drinker also. So history of withdrawals, because whatever withdrawal symptoms they had before, they're likely to develop again. History of DTs or withdrawal seizures is really important because, again, they're likely to develop at this time. And if they have that history and they're already having signs of withdrawal right now, these are patients that you really want to consider getting an IV on really early, just to get ahead of the game. You want to ask about drug use as well, mental health questions, so screening for SI and HI, given the significant overlap with alcohol use disorder and mental health disorders. And then lastly, you want to ask yourself, why did they stop drinking? Is it because they actually want to quit drinking? Is it because they no longer have the financial means? Or is it because there's an underlying medical illness that's causing them to not want to drink anymore? So pancreatitis, ulcers, gastritis, or something even more dangerous. And then always consider your common mimics of withdrawal. So these are going to be your toxic metabolic causes, other alcohols, opiates or sedatives, prescription or illicit drug use, neuro abnormalities, and infections, just as general categories. So we get to the physical exam. Patient's diaphoretic, appears anxious. On HENT, you see tongue fasciculations, and on MSK, hand tremors when arms and wrists are extended. Otherwise, neuro exam, non-focal, able to gait, CV respiratory abdomen benign. So this patient is suffering from mild withdrawal symptoms. So generally characterized by ear insomnia, ear intention tremor. So specifically, it's not going to be at rest. You can ask them to extend their arms, and if they have that tremor. A little pearl I saw while looking this up is that if you hand patients some water and you see the tremor when they extend for it, that's a good sign that this is withdrawals. Mild anxiety, a physical exam. So things to look for here. They can have sinus tachycardia, systolic hypertension, and also tongue fasciculations are pretty specific for this. These are apparently very hard to fake. So usually within 6 hours of their last drink, but it could also be just a decrease from their baseline of drinking. So if they drink like 16 beers a day and they've only had like 6 today, they can still be withdrawing. So you maybe give this patient benzodiazepine, and we'll talk about options later. You go and see more patients, and then you come back and reevaluate, and now they're having hallucinations. So patients stating they're seeing Kermit the Frog running across the room, they feel bugs crawling on their skin. Physical exam, you see they have mild tachycardia, mild hypertension. They're responding to internal stimuli, they're scratching at themselves, but you ask them and their ANO ×3, they actually seem to be aware that they're having these hallucinations. This patient's having alcohol withdrawal hallucinosis. General timeline from last drink, usually 12 to 48 hours, and they tend to resolve within 24 to 48 hours after onset. They're usually visual or tactile, so insects and animals are one of the more documented manifestations. And you want to distinguish this from delirium tremens, which is the more scarier thing here. And the way you do that is they tend to have intact orientation. So they're aware that they're having these hallucinations. And then vital signs tend to be pretty normal. So say it's a new shift, you're handed off a patient and you were told they're in alcohol withdrawals. They've already been given Librium 50. And as you're seeing a new patient, nurse comes up to you, says, hey, your patient's having a seizure. You go and evaluate really quickly. You see it's a tonic-clonic seizure, and it actually resolves pretty quickly after you arrive at bedside. And postdictally, they're almost immediately back to baseline. This patient is having withdrawal seizures. So characterized, generalized tonic-clonic, or tonic-clonic. They tend to have short to even no postdictal period. And they can be singular, but also they can tend to come in flurries, so really quick back-to-back ones. Timeline for this, 6 to 48 hours after the last drink, but again, it can occur earlier, so always be aware of that. Prevalence-wise, it's in 10 to 30% of patients with withdrawal. And it's important to note that they rarely cause status epilepticus, only around 3%. So if your patient is going into status, you really need to expand your differential and work up accordingly. And last one, say you're on your CCT shift, patient's brought in by EMS, very agitated. You put them on the monitor, you see they're tachycardic, hypertensive, hyperthermic. They're actively hallucinating in front of you, extremely disoriented, diaphoretic. This is the patient you're concerned about, delirium tremens. So characterized by the rapid onset and fluctuating disturbance of attention and cognition. And it's important to note that these patients can also have hallucinations as well. So again, you want to separate this from alcohol withdrawal hallucinosis. And historically, these patients had a 20% mortality rate, which is pretty high. Now it's around 1 to 4% with appropriate treatment. But your most common causes of death here are going to be cardiovascular related, hyperthermia, aspiration, and fluid and electrolyte abnormalities. So you definitely want to do your workup around that. And also, when these patients present, it's hard to know, unless you have this history of alcohol use, that they are in DTs. So again, your differential for this is extremely wide. So we're going to jump to management strategies here. So generally, there's 3 ways of thinking about how to do this. There's your symptom triggered, which is the preferred option. This is when you use CWA and say, okay, this patient has a CWA greater than 8. I'm going to treat them with a benzodiazepine, say Q1 hour, and reevaluate, see if their CWA is now below 8. There's your front loading approach where, say you have a patient with history of DTs or withdrawal seizures, or they have significant comorbidities and you don't think they'd be able to handle going through DTs or a seizure, like just their body would not be able to handle the hyperaginotic state. This option is like, say, giving Valium 10 milligrams Q to 5 to 10 minutes until you reach the sedation goal of drowsy but arousable. And then there's a fixed dose strategy where you're going to give this patient, like, I'm going to give Librium 500 milligrams Q6 hours for 24 hours. This one has been proven multiple times to extend length of stay, and also they have higher amounts of benzodiazepines that you're given. So we tend to not try to use this when we can. And then I'm going to touch on CWA real quickly. It's not validated in the emergency departments. It's just worth noting, but it is the most well-known and most used one we have here. And it's important that patient needs to be able to communicate with you to actually use a CWA. So if they have altered mental status, you can't use it. And a lot of the symptoms can be feigned. So just something to keep in mind. Common medications here that we use. So your Librium is a good PO option, a good option for mild withdrawal, 25 to 100 milligrams, long acting, slow onset. Then there's your Valium, which when looking up treatment strategies for this, the IV option, 5 to 10 milligrams, is a really good option for your seizures or DTs, given that it's long acting, fast onset, and you can titrate pretty quickly. There's your Ativan, which is used more often here. You can do IV, IM, 2 to 4 milligrams. It's short acting, intermediate onset, and it's your go-to for patients that have advanced cirrhosis or acute alcoholic hepatitis. And then there's your Versed IM, 2 to 5 milligrams. This is kind of your go-to option if the patient's having a seizure or in DTs and they don't already have a line, and you need to get at least a little bit of sedation to try to put in that line. Some backup medications here. So your phenobarbital. I know Christy Sim recently just did her presentation talking about this and how Denver has examples of implementing phenobarbital into their protocols. Again, there's some data for this, but I don't think we're there yet. There's your there's your propofol, which is generally an adjunct if you're at the point of intubation for these patients. There's your Precedex or dexmedetomidine. Good for sedation, doesn't actually treat the withdrawal, so kind of stay away from there. And then your ketamine, which has good retrospective studies regarding this, but this is more of something for the future. So for your mild withdrawals, you're generally going to try to do a symptom-based one. So you'll treat with, say, Librium if their CUA is greater than 8. You'll reassess Q1 hours if you can. There's also a self-management option. So if you're talking to the patient and they look like they're dischargeable and they say, I'm going to drink after this, they can be discharged and manage their withdrawals that way. You also want to look at common electrolyte abnormalities. So these patients tend to have hypokalemia, hypomagnesemia, hypophosphatemia, and they also tend to be hypoglycemic as well. So when you replete these, you usually want to go with the IV strategy because of GI absorption in patients with alcoholism is pretty bad. And then vitamins wise, so repleting folate and then dosing for thiamine. It's 100 to 500 milligrams, really depending on your suspicion of whether they have Wernicke's or not. And then if these patients come in and they want to stop drinking, then these are the patients that you really want to connect with the rehab services so that you can help them out of this situation. And then dispo-wise, so for symptomatic patients, if they have a history of complicated withdrawal, if they have severe underlying comorbidities, or if they've needed multiple doses of benzodiazepines, this is going to be a likely admission. If they have none of these, then these patients can actually be discharged pretty safely. So treatment for alcohol withdrawal hallucinosis, this is actually a blind spot in terms of my understanding. No one really explained what the treatment for this was, but this is just considered moderate to severe withdrawal, so you'll treat this with benzodiazepines as well. Antipsychotics is maybe a knee-jerk reaction, and you can treat with this, but again, you might be masking withdrawal symptoms if you do this. And then seizures and DTs, so there's no exact science to this, but for the most part, it's going to be large amounts of benzodiazepines at escalating doses. And so here I have like benzos, more benzos. I'm not trying to be like facetious with this. It's more of just to reiterate the point that these patients are going to need large amounts of benzodiazepines often to get them out of this. They also are likely going to need physical restraints until sedation is reached. A common concern is that, what if I give them respiratory depression with all these benzodiazepines? But at this point, if they're needing this much, they're likely on their way to intubation anyways. And these patients are likely going to need ICU evaluation and a pretty significant workup. And then there's no specific cutoffs in terms of the amount of benzodiazepines that you're going to that you give, say, in the first hour before you call it refractory DTs. Some have mentioned like if you use more than 50 of Valium in the first hour or more than 200 in the first 3 to 4 hours, at that point you can consider calling toxicology or poison control just for a little backup. But here for the major keys, for patients with alcohol use disorder, concern for withdrawal, you want to always ask withdrawal history. You want to always ask yourself, why did they stop drinking? If they have a history of withdrawals or DTs and they're symptomatic in front of you, you really want to get an IV on these patients pretty early just to get ahead of the game. They may require more benzos than you think, especially your patients with DTs. And then your sedation goal here is sleepy but arousable. And these are my references. Thank you, Dr. Delgado, Dr. Pandya, and Dr. Raber. Any questions? Go Cowboys.